Welcome to the Eat Away Kidney Stones podcast. I'm your host, registered dietitian and kidney stone expert, Melanie Betts. After learning a ton about kidney stones and helping people prevent stones at the University of Chicago, I was fed up with all the terrible advice people were finding online. So I decided to do something about it. The Kidney Dietitian was born. This podcast is for people who want to learn what actually works to prevent kidney stones and still enjoy life, eating, and their favorite foods. Let's dive in. Hello and welcome to the 95th episode of the Eat Away Kidney Stones podcast. As always, I'm your host, registered dietitian and kidney stone expert, Melanie Betts, and I am thrilled to welcome a very special guest to the podcast this week. Her name is Bianca Gallub, and she is a pelvic floor physical therapist. So you know a little bit about her, here's a little bit of her background. She got a Master of Science in Occupational Therapy from Columbia University, and she graduated magna cum laude with a Bachelor of Arts from Hofstra University. Bianca has experienced treating a wide variety of diagnoses, including musculoskeletal impairments, neurodegenerative diseases, neurological impairments, mental health, and pediatrics. She has advanced training in pelvic health through Herman and Wallace Pelvic Rehabilitation Institute. And when working with her patients, she's able to provide support for bowel, bladder, which is what we're going to talk about today, sexual and or pregnancy, postpartum related issues, which is actually where I met Bianca initially. I was a patient when I had twins about 3 years ago. So it's so fun to see you, Bianca, and welcome to the podcast.
Thank you so much for having me.
Yes. So before we start out, I gave everyone like sort of our textbook background of what you do, but like, what is pelvic floor PT? Can you, in like layman's terms, tell us what it is that you help people do?
Absolutely. So I like to divide it kind of into three different categories, but I do see both men and women clients. So the three different categories that I see predominantly are prenatal patients, postpartum patients, and then also my general pelvic patients as well. So people come in usually for an evaluation and they kind of tell me what's going on. My prenatal patients, they may be experiencing some pelvic pain, or they might be experiencing bladder leakage, or they might be experiencing painful intercourse. And we do a thorough assessment, kind of evaluating what's going on, where's their strength at, and kind of see what does their everyday ADLs look like? What's important to them? What are some goals? And from there, we kind of make a treatment plan. Mm-hmm. Then I go off to my postpartum patients, and that kind of divides into both a C-section and a vaginal birth. I do offer with my postpartum patients, not my prenatal patients, an internal assessment. And then some people come in and they say, what does that include? So I explain everything before we even get started. I like to tell patients I'm very verbal with my assessments. I like to first visually and externally, view the vulva, right? I explain the anatomy to them, how the pelvic floor has all these different muscles with different functions. And from there, I explain the internal assessment. And what I usually do is with my first digit of my finger, I palpate externally on the vulva, and then I insert that into the three different layers of the pelvic floor. There's three different layers of the pelvic floor. There's all these different muscles with different functions. And I usually palpate those muscles. I feel for people's Kegel strength grades, and then we could do treatment from there. So that's kind of like a postpartum initial evaluation. And from there, we go outside in the clinic, and then I give them some exercises that they can perform in the clinic, and then also at home for home exercise. And then my general pelvic patients, they come in for painful, intercourse. They come in for maybe low back pain, or even some, bladder leakage that they've experienced, from puberty till current. So those are kind of my three different patients that I see in pelvic floor therapy. Mm-hmm. I like to find that it's a new and upcoming field, and more people over time are finding out about it.
Yeah, I have to say, pelvic floor PT, both before and after pregnancy, like changed my pregnancy. Like I had not the best experience with pregnancy. Pregnancy with twins is no joke. But like just having someone, if nothing else, just who was there to listen and who actually had something that I could do, I'd be like, you know what, like I can't sleep because my hip hurts so much. That was my most consistent thing. Like, because I had all that extra weight. I was laying on my side and my bottom hip hurt so much. And Erin, who I was working with at the time, not only was she like, oh, like you're pregnant, like of course you're in pain because that's what doctors typically say, right? But she's like, oh, like here's some things we can try with pillows and maybe some exercises. And she like did some stuff that actually made it better, gave me tips to actually make it better. And it's just mind blowing to me. This is a bit off topic because we're talking about bladder stuff, but I just feel like it is insane to me that pelvic floor PT is not required or at least offered to every single pregnant person in the world because it can do wonders. So I feel like I'm a evangelist for for like pelvic floor PT. So like thank you so much for what you do.
Absolutely. And I'm so happy to be doing podcasts like this so that more people find out about the field and that we do see patients during their prenatal time so that they could feel
Yeah.
really good. They could feel active throughout their pregnancies and not have any pelvic pain or symptoms.
Yeah, absolutely. And I think maybe I'm biased because of my experience, but I feel like pelvic floor PT is most known for pregnancy stuff. Would you say that's fair?
Yeah, and I think even what's missed too that I hear with a lot of my patients is that if you have a C-section, people think, no, that wouldn't be, my type of physical therapy, but we see plenty of C-section patients as well.
Yeah.
So, like I said earlier, I think it's split up where I have my prenatal patients, postpartum,
So
and
kind
then my general pelvic patients. But the problem is not a lot of people know about the field.
And there's not many of you. Would you say there's a shortage as well, which is a whole nother issue?
Definitely. I think that there's a need. There's not a lot of pelvic floor therapists.
hmm
And in some states, there's a lot of wait lists. So even if you're experiencing any pelvic pain or symptoms at the time, you might be in a wait list for 3 to 6 months to try to get in just for an eval with a provider.
Yeah, yeah. It is mind blowing. Like I've learned so much, and I'm sure I'm going to learn a ton on the podcast today, even just like all of the different things that pelvic floor therapy does. Like it's not just pregnancy, right? Like we're going to focus today on bladder control essentially because that is something that I hear every day from people that I'm working with who are trying to just drink a ton more water to prevent stones and then there's the obvious issue with peeing a lot. But it's just mind-blowing like all of the different areas that pelvic floor PT can help. And I'm actually going to have Bianca's counterpart, Erin, on in a couple of months to talk about sort of pelvic floor PT in general. So definitely watch out for that episode if you're interested. And before we dive into bladder, I have to ask you, Bianca, why pelvic floor PT? Like, why did you decide to specialize in this? Like, is there some big story, or you just liked it? Like, why this?
Absolutely. I have a love for women's health, both the anatomy and, helping patients. I've had my own pelvic floor journey in the process, which led me here to working in this beautiful specialty that I full-heartedly believe in. I know it works because I've been on the patient side myself. I
hmm
got diagnosed a couple of years with interstitial cystitis.
hmm
It actually kind of goes along with the category and the topic that we're going to be talking about
Definitely.
today. Interstitial cystitis is painful bladder syndrome. The cause is unknown. We really don't know why it happens, but there's a couple of triggers that could exacerbate your symptoms. So I actually had my own pelvic journey of why is this happening to me? I didn't even have a name to it. I didn't even have the diagnosis. But I ended up
Mhm.
seeing so many wonderful pelvic floor therapists who helped change the quality of my life. So that kind of led me to this beautiful field that I
Yeah.
work in.
I didn't know that. That's so cool. I have learned a ton about IC because I've connected with a dietitian who specializes in IC. Her handle is Callie K Nutrition. I'll link to it in the show notes if anyone wants to listen in. She's wonderful and I've learned so much and she has IC herself and also speaks volumes about pelvic floor PT and how important it is for for IC. So and unsurprisingly, like most areas in women's health, we don't know a ton about it. And but that being said, there is still so much that we can do. So awesome. Awesome. Okay. So moving on to bladder stuff. Um, what would you describe a normal bowel habit to be? Like how many times a day should you be going to the bathroom? Like what does normal peeing look like or should look like?
Absolutely. So at an evaluation, I try to get to know my patient and take a look into what is, your everyday routine. So a normal bladder and bowel routine, you should be going to the bathroom number two, 1 to 2 times a day. Having a bowel movement more than once is totally normal, but it really just depends on your most common stool consistency. So I ask my patients, what is your stool looking like, right? What is it afterwards when you wipe? So we take a deep dive into those types of questions. But a normal bladder routine is you should be able to hold your bladder about 2 to 3 to 4 hours in
So you
between.
shouldn't be peeing more than 2 to 4 hours.
Absolutely. I have
Okay.
patients that come in where they have 1, 2, 3 times of a urination or a void within 1 hour. And it's physically impossible, with a normal and appropriate fluid intake for your bladder to be filling to its max capacity, which is about
Hmm.
600 milliliters of urine. So you should be spreading that out. You should be able to hold that. And then also at night, you should be going 0 to 1 times in the middle of the night. I have patients that come in and they have urination streams in the middle of the night, 1, 2, 3 times, and it really could affect your
Yeah.
quality of sleep.
Yeah.
But
And
that's what
health,
a normal,
truly.
yes,
Yeah.
absolutely. And that's what a normal bladder and bowel routine should look like in the
Okay.
day.
Okay. So as I mentioned earlier, and this is not a surprise to the listeners of the podcast, definitely the biggest barrier, I think, other than simply remembering to drink a lot of water, but I feel like the biggest, most difficult barrier that I find is that people find that drinking all this water, because for kidney stones, we typically aim for at least 2.5 liters of output per day. So I'm typically telling people to drink around 3 liters of fluid per day, which is a lot. That is like double the average output. So it is a lot. And people will say, especially like occupational barriers such as teachers or taxi drivers or truck drivers, right? Like I can't go pee all the time. Like I cannot leave my job, or it's just annoying to have to get up and pee all the time. And so this is such a barrier to meeting our goals for kidney stone prevention. And so what would you say to someone who is experiencing something like that? Like Bianca, like I am going pee every hour and a half. What can I do to make this better?
Absolutely. So if you're limiting your fluid intake or your water intake, that actually can make your urine output more concentrated, which could lead to a bladder trigger, a bladder irritant, and it can make you have more frequent urination or increased
Hmm.
frequency of
I
urination.
literally
You
didn't know.
want, yes, you want to have a nice balance of the two. You don't want your urine to be too diluted where you're overpowering your bladder and you're peeing more than, that 1 time per 2 to 3 hours.
Hmm.
But you want to make sure that it's not too concentrated or acidic, where it's going to trigger your bladder into thinking that it's already full. So I like
Hmm.
to tell my patients, take your body weight, divide it in half, and that's the amount of ounces in water that you should be drinking per day. Of course, there's patients that come in who drink very, very low ounces of water. So I like to start it off small. I don't want to overpower the bladder right from the get-go. So I say, okay, let's see where we're at. Let's double that, and we'll slowly increase our,
Hmm.
our water intake. And then from there, if someone's having, any urgency of urination with good and appropriate fluid intake, we could put them on a bladder schedule as well. What we could do is we could time their voids, right? So if they're forgetting to urinate or they just don't have that time throughout the day due to their occupation, whether it's nursing or teaching, or a very physical job where they don't have access to a bathroom, I like to say, okay, at this time of the hour, you're going to go to the bathroom and kind of train that bladder to relax on the toilets, and set that tone for them. So then
Hmm.
you're retraining that bladder. Then there's also, behavioral modifications that come into play as well, where we want to limit any irritants for the bladder. That can include any alcohol that could irritate the bladder. That could include anything citrus. That also could include caffeine, which is a big part of my, prenatal and postpartum patients' life. But we want to make sure that with that caffeine, there's an appropriate amount of fluid intake.
Hmm. Yeah. Interesting. Interesting. Um, and something that was very surprising to me and that I think made a big difference for me when I was pregnant. So this with that is I was going to the bathroom because I kind of felt like I had to. I was working from home at the time and I was just going to the bathroom just because I'd walk past the bathroom. It's like, well, I'm up, might as well. So this is kind of, I think, going back to that bladder schedule that you were talking about. So can you talk a little bit about how that works and how you can sort of train your bladder to hold on to that pee for longer? That's kind of what's going on there, right?
Absolutely. So what
Yeah.
you had just described is called just in case peas.
I did that all the time.
We like
I
to
still
not
do.
have just in
Yeah.
case peas because what it's doing is if you go to the bathroom and you have a urine stream that's less than 8 seconds, what it does is it's training the bladder that every time it's going to fill at that amount of cc's that you just emptied at, it's training the bladder that it's full, right? So it's going to
Hmm.
send signals from the
Like
brain down to
I'm
the
good.
bladder. Right, that
Hmm.
we need to act on that urge and we need to empty. And over time, that can be really debilitating and really irritating as well. Of course, there's different, exceptions to this rule of just in case urination. If you're going on a long car ride or if you're not going to have access to a bathroom where there's like a porta potty, things like that. But of course, going back to your original question, we want to make sure that They're having that voiding schedule to train the bladder that we could hold it, and it's going to be okay. Of course,
Hmm.
pelvic floor therapy comes into play, working on strengthening those muscles so that you could actually hold your urine in the bladder, but definitely don't want to be urinating more than once within that 2 to 3 hour time because that could disrupt the nerves and it can disrupt the signals from the brain to the
Hmm.
bladder.
Would you say that even kidney stone patients who are trying to drink a lot more than what we would typically recommend, would you still say that it's appropriate to aim for no more frequent pees than every 3 hours or so, 3 to 4 hours? Would you say that's still a good guideline?
It really depends. What I could also do with my patients as well is I put them on a bladder diary, right? I want to take a look into what is their day looking like, right? What is the color of their urine? What is the amount of their urine? How did they feel after they got up from the toilet and wiped? Did they have dribbling? Did they walk away feeling really good? So I like to put my patients on a bladder diary to find out that information. And then from there, we could assess and then make an appropriate bladder voiding schedule that works best for their lifestyle. Of
Hmm.
course, people have, different schedules throughout their day where sometimes, they might not have access to the bathroom in a 2 to 3 hour, range. For example, going off of that, I might have some patients who maybe are, therapists and they only have 50 minutes. And if they were put on a bladder schedule, and it was in the middle of their, client session, they weren't able.
Obviously. Hmm.
Right. So I want to make sure that we do that bladder diary, I take a look into their lifestyle, and then we make a timeline based off of their life.
Yeah, yeah, that makes a lot of sense. Different for everyone. Never one size fits all thing in healthcare, right? Yeah. Um, how long would you say it takes for this sort of bladder training, bladder schedule to work? Like, are we talking a week, 6 months, a year? Like, how long does it take to train your bladder to hold that larger volume of liquid?
Absolutely. So I always like to say that it takes the body about 2 weeks to kind of get used to something new, right? But of course, it really depends on the weakness of someone's pelvic floor. Like, where are they starting upon that initial evaluation, right? So it really could vary patient to patient. I like to give it a good 6 weeks before we seeing, some positive reinforcement of good, healthy bladder routine.
Okay,
So I would
that's
say
help.
about 6 weeks.
Yeah, okay. That's helpful. That's some context of what we're talking about, you know. Yeah,
But
not a year, but not a week.
yeah, and of course,
Yeah.
I've had, some patients where I've eval them and they see the difference with those behavioral modifications or even some treatment from one session to the next, which I think is
Hmm.
amazing. And it
Yeah.
really shows that this field really does wonders.
Yeah, absolutely. So what we have a lot of people listening to this podcast, and I can't imagine that everyone would have to see a pelvic floor PT. As much as I love pelvic floor PT, and I'm sure everyone could benefit, but like, what are some signs that your bladder situation could benefit from going to see a pelvic floor PT? Like, what would be some signs where you'd be like, yeah, I should maybe try to find one in my area?
Absolutely. So, any signs, that is outside of any bladder symptoms, it could also show up that you need pelvic floor therapy if you have pelvic pain. That can include pelvic girdle pain, low back pain. It can include hip pain. It can include groin pain. That's kind of like that pelvic girdle pain.
Hmm.
So patients that have, any of that pelvic girdle or low back pain, when I ask them in an eval, tell me a little bit about your pain or your lifestyle. Usually bladder symptoms show up in that eval as well. But
Even though
also
that may not be why they came to see you necessarily.
exactly.
Hmm.
That may not initially be why they came in, but also painful intercourse as well. If you have overactive pelvic floor muscles, that can go hand in hand with any bladder symptoms or any bowel symptoms that you might have as well. So those are
Hmm.
kind of the telltale signs. Am I having pelvic pain throughout the day, which is impeding on my everyday ADLs? Of course, am I having any bladder symptoms like, stress incontinence, urge incontinence, even mixed incontinence, which is a combo of both? Or am I having any, painful intercourse, which is more common than we think?
Hmm. Okay. Got it. And so would you say that if someone isn't having any of those other symptoms and just finds that they're having to go to the bathroom every hour, would that be enough to warrant going to see a pelvic floor PT?
I'm kind of biased because I always think that patients could always benefit from pelvic floor
Yeah.
therapy. Because even, in post-COVID times, a lot of us have hybrid work from homes and an office where they're sitting for long periods at a desk. So poor posture can also impact our pelvic floor musculature and kind of how it shows up. So
Mhm.
I'm biased. I always think that everyone could
Yeah.
benefit from pelvic floor therapy, both men
Yeah.
and women.
Yeah, and why not, honestly? Like what's the harm? Like it's some time and some money potentially, but like there's not really, m many barriers. Wait, well, going back to harm, I did want to ask you from the beginning of the episode when you were talking about the internal exam. I feel like a lot of people immediately think about that with pelvic floor PT, but it sounds like that's not always necessary. Even for depending on why you're going. And I have to imagine that if you really don't feel comfortable with it, like that's not required to happen. So maybe you could provide some clarification around that topic.
Absolutely. So I definitely do not have to provide an internal assessment if my patients are uncomfortable. I could palpate pelvic floor externally over the pants. I find my landmarks, and then we go through kind of like your Kegel strength grades. What I'm looking for there in both an internal and external assessment to try to see how is the musculature responding is your pelvic floor motor control, your kinesthetic awareness of pelvic floor, your strength and endurance. But we definitely do not have to perform an internal assessment if that's not something you're comfortable with. I also don't perform an internal assessment on my prenatal patients. I only offer that to my postpartum and my general pelvic patients as well. But I know that does vary from different, clinician to clinician.
Okay. All right. Got it. And I also wanted to talk about leakage, which I didn't plan on talking about, but I'm sure that that is an issue that a lot of people experience, especially when we're trying to get in these large volumes. So, what's going on with urine leakage, especially, I feel like this is probably a very taboo topic because you think about, this only happens to old people, but that I think is definitely not the case, especially for women post having babies. So talk a little bit about leakage, why that happens, and what we can do to help with that as well.
Absolutely. So there's three different categories of leakage. So earlier I had mentioned stress incontinence, urge incontinence, and then mixed incontinence. To explain those three, stress incontinence would be bladder leakage with any, improper pressure management. So that would be sneezing, coughing,
Mm.
laughing.
Trampolines.
Exactly. Jumping or just
Yes.
jumping outside on trampolines, or even, like with running as well.
Mm-hmm.
That could be stress incontinence. Urge incontinence could be you can't quite hold your bladder to make your way to the bathroom. So, for example, if you're in a car and you're almost at home and you're like, I really have to use the bathroom, and you can't hold it in time before making your way home, you could have, bladder leakage with that. Or let's say you're on a long grocery line and it's longer than expected, and you're like, I just came in, to purchase one item. I didn't think this line would take that long, and then you have a full, bladder leakage from there. Some people can have a combination of both. They can have something called mixed incontinence, which is, you can't quite hold your bladder with the urge incontinence, but also you have bladder leakage with sneezing, coughing, laughing, jumping as well. So we have to assess the patient, what is kind of going on there. And from there, we kind of assess, is their pelvic floor muscles too overactive? Are they too weak? And that's where kind of that internal and external assessment comes in handy too. With my postpartum patients, they might be having something called diastasis recti, which could be an ab separation that anatomically has to happen in order for baby to fit in the uterus. You have your six pack muscles, you say, that if you imagine an anatomy textbook, your six pack muscles, and those are what separate so that baby could fit in your uterus. And if you put too much strain on your core during pregnancy, you could pull up that connective tissue that holds those muscles together. That could lead to a lot of pelvic floor weakness. And that is very, very common for my postpartum patients, which can contribute to any bladder leakage. So a treatment plan, depending on where they present, are they presenting where their pelvic floor muscles are hypotonic, where they're too weak and they're lacking that tone? Are they presenting where it's overactive and they're hypertonic? We make a treatment plan on there to strengthen not only the pelvic girdle, but the core as well.
It's fascinating, Bianca. Like, I feel like the take home message should be this is so complicated, and there are so many gazillions of things that could be going on. If you have any of these issues, just go see a PT and see if there's something you can do. Like, there's because I wanted to ask, like, are there certain exercises that we can do? And I'm sure the answer is no, because it's going to depend on your muscles. Are they hyperactive or weak? Or also, like, the pelvic floor isn't just one muscle. I imagine it is many, many, many muscles,
Yeah.
right? So, it's just, and different exercises are obviously going to target different things. So it's just so complicated. There's so many things to know. It's fascinating, truly.
Absolutely. And also going off of what I just said with postpartum patients, I have patients who've never had children and they say, I've been having bladder leakage for 10 years. Most of the time, that does go along with having pelvic pain or low back pain as well. Those kind of go hand in hand. So I want to say to patients out there who are experiencing bladder leakage that don't have children, come into pelvic floor therapy. It's not just for my prenatal or postpartum patients.
Hmm. Yeah. When you say pelvic pain, can you specify what you mean by that a little bit more?
So pelvic pain. So that could be pain at your pubic bone. That could be pain in the glutes. Going off of that, that can go down your leg and you can have referred pain. You can have pain in your SI joint and your low back. You can have pain externally at the vulva. You could feel a heaviness in the pelvic floor where it feels like a tampon stuck in there, even though you didn't insert a tampon. It can kind of present in, many different ways. But think of it as like your hip muscles and kind of wrapping around that pelvic girdle. Any of those muscles that can present as pain could be considered pelvic pain.
Basically anything from like under your ribs to like above your knees, it sounds like. Any of that could, and probably more, but maybe those are the primary areas.
And from there, there's a lot of nerves in there, so you can get referred pain from there as well.
Hmm. It's fascinating. I have to ask, what do you think of Kegels?
Kegels, a lot of people read about it. Kegels aren't always the best for my patients. It's usually not my first line of defense, right? Because Kegels can actually make your symptoms worse if not done right. Okay. So if someone has a hypertonic pelvic floor or an overactive pelvic floor or a too tight pelvic floor, Kegels are not my first line of defense. We should be able to do our Kegels. So I eventually get to Kegels with my patients, but sometimes people need a down regulation of their nervous system. They need a protocol from the get-go where you're relaxing those pelvic floor muscles. Your pelvic floor muscles, think of it as like a hammock for bladder, uterus, and rectum, okay? It should be able to hold those vital organs, okay? If everything is tightening up, it's too tight, and it's saying, I need to do this in order to hold those vital organs, you might not fully be able to relax those pelvic floor muscles when you're on the toilet or in your everyday ADLs. Your pelvic floor muscles, just like any other muscles in your body, like a bicep, for example, they should have the ability to contract, but also relax. So sometimes if people are doing Kegels inappropriately, right, it could make their pelvic symptoms worse because they could be using other accessory muscles, which include adductors, your inner thigh muscles, your glutes, or even their back, right? They could be using those muscles to kind of compensate for the lack of the pelvic floor strength that they
Hmm.
have. So we kind of have to see, where's their Kegel strength grade at? Are they not doing a Kegel at all? Are they clenching and overactivating those muscles? So it really just depends, but Kegels are not always the best treatment plans for my patients.
Hmm. Yes. That was also fascinating. I learned that when I was in pelvic floor PT as well. That was not necessarily a good thing, which was mind blowing at the time. Okay, I have two more bladder habits that I hear about frequently with people that I'm working with. The first one I want to ask about is feeling like you can't fully empty your bladder. What's going on there?
Absolutely. So going off of what we had just discussed, right? If you're on the toilet and those muscles are too overactive, you might not fully be emptying your urine, right? So you might walk away from the toilet and say, I still feel like I have to pee. Some people might go back into the toilet. They might sit on the toilet as well, and more urine might be coming out, right? If they're fully not relaxing their pelvic floor muscles, what's going on? Is it
Hmm.
coming a weakness? Is it coming from that overactivity? We kind of have to see what's going on that's contributing to them having that incomplete bladder emptying.
Yeah.
And from there, we make a pelvic floor assessment and then treatment.
Yeah. And I imagine if you aren't fully emptying your bladder, that's obviously going to contribute to that urinary frequency, right? Needing to go to the bathroom all the time.
Yeah, it's very, very debilitating. I also have a lot of patients too where they don't give their pelvic floor time to fully relax when they're on the toilet.
You're like, go, 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 go.
Exactly. They'll go in the
Hmm.
toilets and they're kind of pushing and bearing down their urine stream and they fully didn't relax. And instead, what they're doing is they're contracting when they're on the toilets. They're not
Hmm.
giving the pelvic floor muscles fully time to relax because they're rushing and they're trying to get in and out of the toilet quickly, depending on their lifestyle. Also, what they could be doing is they could be walking away and then they could be going back to their everyday compensations, which is leading to that overactivity of their pelvic floor. Their pelvic floor is not having that strength, so they're tightening up or they're clenching throughout the day, which is contributing to why they're not having that full emptying of the bladder.
Hmm. So even thinking about how you pee, which is probably something you've never thought about before in your whole life, but it sounds like taking time to go, sit, relax, maybe don't be on Instagram, don't be on your phone, like, and just like being present, right? Maybe, can you walk us through like what else am I missing? Like what should we be doing when we go to pee? And is it different for men and women? Or
Yeah, no, it's the same. So I always like to tell people squatty potty is your best friend. And that acts for both, voiding for bladder and your bowels. And
okay,
once you use the squatty potty, oh my gosh,
you'll never go back.
you'll never go back. At our clinic, we have it in all of our toilets, and we just highly recommend it for our patients because what it does is it places your pelvis and your hips in a proper position where you could fully relax on the toilet. So I always ask people, do you have a squatty potty? And I don't get any commissions or anything from squatty potty. I just really love the product. It works and it really helps so that you could sit on the toilet and fully relax those muscles. So I'm pro squatty potty. And like I said,
Hmm.
that's best for both bladder and bowels. And then going off of there, we also want to make sure that we're not hovering over the toilets. A
Mm.
lot of my patients hover over the toilets. And what that is, hovering, is you're kind of squatting over the toilet without fully sitting down. If I'm in a squatted position, I'm contracting those pelvic floor muscles to kind of hold me up. And that's going to impede on me relaxing as well. So if I'm not sitting on the toilet and fully relaxing those muscles so that I can have good urine output, or I'm not giving the amount of time that I could to fully relax, or if I'm hovering over the toilet, that can lead to that incomplete emptying of the bladder.
Fascinating. I did not know squatty potties were good for peeing as well. I'm learning so many things. This is
I
fascinating.
tell people to for hovering, just looking into a little bit of behavioral modifications that I like to make with my patients. I say, if you're really, nervous about sitting on maybe a public bathroom, on Amazon or online, they have those kind of liners that you can put
Mhm.
on and carry in your purse, or even Lysol wipes, just wiping it and then throwing it in the garbage, and then we could fully, sit on the toilet and give the, your pelvic floor time to relax.
Yeah. What about if you're like you're at a concert and like there's just porta potties and it's so gross. Like I have to imagine that peeing, like hovering in those situations occasionally is not going to kill you, right? It's not going to totally
Absolutely.
screw up your pelvic floor.
No, that is my exception. If you're on a if you're on a porta potty that you really feel this is not hygienic, right?
So gross.
Um, that is okay, and then afterwards, maybe then when we go home, we need to perform a little bit more stretching and then make sure we have, an appropriate fluid intake. But that is definitely an exception to the rule. And then in pelvic floor therapy, we want to make sure, do we have that flexibility and that strength so that we could perform a squat when we're on, at a concert or in a public restroom, or a porta potty that's just a little bit yucky.
Yeah.
So those are some of the things that as well that we work on as well. Do they have that flexibility so that they can hold themselves up? Do they have that strength that they can hold themselves up in a squat to kind of hover over the toilet?
Hmm. Yeah. Awesome. Awesome. All right. The last question that I have is nocturia. So going to the bathroom at night many times. I think, my sort of blanket advice for people is kind of finding a balance between getting in all that water that we know is so important for the prevention of kidney stones, but also not drinking so much that you're waking up at night 6 times because that is not good for anyone. Like sleep is perhaps the most important thing for health, I swear. Right. So, if someone is experiencing going to the bathroom so much that it's impacting their quality of life and they feel super sleepy, like what can we do about that?
Absolutely. So I always ask my patients, what's waking you up? Is your bladder waking you up where you have to
Or
go to the bathroom, or
Mhm.
is pain waking you up? And then
Or
from there,
anxiety.
exactly.
Yeah.
Right?
Yeah.
So is pain waking me up? And you're tossing and turning, and you're like, okay, maybe it's my bladder as well. And then they end up going to the toilet. So you want to aim for 0 to 1 times throughout the night. You should never be up, every hour on the hour, because that could really impede on your sleep. So I like to tell my patients, make sure you're having an appropriate fluid intake. A bulk of your water should be throughout the day. You should never be overpowering your bladder at dinner time. Some of my patients, what happens is that, their day gets ahead of them, away from them, and they're like, I did not drink a lot of water
And then you
today.
chug a ton of it.
They chug a
Yes.
ton of water. So you want to
Hmm.
make sure that you're not chugging a ton of water. You want to make sure you're sipping throughout the day and the bulk of the water is happening in the morning or the afternoon. And then we kind of have to taper off towards the end of that evening. I like to tell my patients you should kind of limit your water intake about 2 hours prior to bed. And that's not to say that you can't sip your water, because some people have to take nighttime medications where they need water in order to wash down their pills or their medication. So at least 2 hours before, so that we're not overpowering our bladder. And then, of course, sleep hygiene. We want to make sure that we have a really nice sleep routine. Okay. That could include, getting to bed at, a decent hour every night, making sure that we're not exposing our eyes, to blue lights, making sure that we're really comfortable in bed in a comfortable position with a bunch of pillows, and making sure that we have optimal temperature as well. And that could, aid in having us really nice quality sleep and to not keep us up all night in order
Hmm.
to having a lot of
Yeah.
yeah.
That's such a good point of kind of ruling out other issues that might be waking you up, like having that good sleep hygiene and anxiety or pain, right? There's so many things, and you're assuming that it's your bladder, but perhaps it isn't. Yeah, that's a great
Absolutely. There
point.
could be other reasons as to why that's keeping you up. And people think if I go to the bathroom, I'm going to empty it and then I'm going to get back to sleep. But that
Hmm.
won't always be the case.
Yeah. Or I'm up anyway, might as well go pee, right? If you kind and perhaps that's like a vicious
Yeah,
cycle, and then you end up you're training your body to do that potentially, I imagine.
absolutely.
Yeah. All right. Any last thoughts? We covered so many things. Any last thoughts that you would like to leave our listeners with?
Oh, absolutely. So if you think that you're experiencing any of the symptoms that we had discussed today in this podcast, please come in for a pelvic floor assessment, because you might not have to be in pelvic floor therapy, for 6 months to a year. You might just need a couple of sessions. So go in, see a provider, tell them what's going on in your life, and they could definitely, definitely help you. It has done wonders for my life, and I really just believe in the field. It just works, and go in and get an assessment.
Yeah, yeah. And also, it's not like this is some weird like alternative therapy, like sort of like what I do with food. Like I feel like sometimes I feel like I'm this like unicorn. Is like, no, this is literally like best practice. Like this is just like Western medicine, like good stuff, right? Like this. So anyway, just wanted to throw that in there.
Absolutely. It's
Yeah.
standard practice in, some countries. Hopefully, we're evolving in the United States. And then, if you have a child or if you're having these symptoms, a provider will definitely, refer you to pelvic floor physical
Yeah.
therapist, just like with a knee replacement or a hip replacement, where they refer you to PTOT. Hopefully, in the future, we can evolve to get there.
Yeah. How can you find a pelvic floor physical therapist? Do you think that people can just sort of Google pelvic floor PT and find one in their area? Is there any special tricks that you would have?
Yeah, first and foremost, if you go to an OBGYN or if you go to a urogynecologist, that's an OBGYN that specializes in urology, they could have a list of providers for you. So if you are seeing a provider, they could have that list. But of course, Googling pelvic floor therapists near me, giving them a call, and making sure that they have the adequate certification and licensure for pelvic floor. Because there are some physical therapy clinics that the provider or physical therapist has only taken maybe one pelvic class and isn't really a full specialty. So I want to see, how many patients are pelvic floor therapy in that clinic. Go in and ask your questions when you're making that appointment. But you definitely could Google pelvic floor therapy near me and make sure that your physical therapist has adequate training in pelvic floor
Yeah.
therapy.
Is there a specific credential or like letters after your name that you're looking for that pelvic floor certification?
So many people have different abbreviations
Okay.
based off of their continuing ed classes and then tests that they take. Not specific letters. You want to just make sure that it's a physical therapist or an occupational therapist. Look into their bio. Did they take the pelvic classes while they were in their grad school program? Did they take the pelvic classes through Herman and Wallace Pelvic Institute? Take a look into the provider that's going to be treating you, but also ask the administration, how many pelvic floor patients do you see at your clinic?
Yeah, we don't want it to be like a random one here and there. That's,
Absolutely.
yeah, yeah. Okay, awesome. And where can people find and connect with you, especially if they happen to be in the Chicago area? Where can people find you?
Absolutely. I work at Westtown Physical Therapy at Roscoe Village. The Roscoe Village location is where we perform pelvic floor therapy. So you can take a look on westtownpt.com. My name's Bianca and make an evaluation with me.
Yeah, that's where I went and could not recommend it more highly. So, thank you again, Bianca, so much for your time. This was fascinating. amazing, and I know it will be invaluable to so many people. And thank you everyone for listening. I hope that you enjoyed this fascinating episode with pelvic floor BT.
Thank you. Thank you for
Thank
having me.
you.
Wonderful.
Thank you for listening to today's episode. For more help with kidney stones, check out my website, www.thekidneydietitian.org. For more personalized help from me, check out my online course, Kidney Stone Nutrition School. VIP enrollment includes help directly from me. I can't wait to see you there and help you prevent kidney stones. Have a great day.